Good afternoon, everyone. I'm Janet Hughes. I'm a reporter for Gloucestershire Live. I'm here today because we're doing a series of 6 StreamYards to discuss the future of the NHS in Gloucestershire. And we want to talk about some of the ideas our local NHS has for the future, particularly around hospital services. We've already had Fit for the Future 1, and now we want to talk about 6 more specialisms in Fit for the Future 2. We've discussed many of them over the last week, and now we're on to week 2. And this week we're going to talk about diabetes and endocrinology and cardiology on Friday. But today we've got Dr. Tom Millard, who's in charge of diabetes and endocrinology, and he'll be telling us what the idea is and what he wants to see for the future for the service in Gloucestershire. But first of all, we're going to go to Simon Lansley, who's the Director of Strategy, and we're going to ask you a bit, can you tell us again, remind us a bit what Fit for the Future is about, Simon, and about the vision for Centres of Excellence?
Sure. Yeah, thanks, Janet, and afternoon, everyone. So this is a continuation of our clinical strategy. So viewers may remember in phase 1, we talked about 7 reconfigurations. I'm pleased to say that 5 of those 7 changes have now been implemented, and the remaining 2 will come into play in the summer of 23. So those of you that have been on site recently can see an awful lot of building work going on at the moment, and that's the estate changes that we need to make so that we can then implement those final 2 changes. So phase 2 is about 6 other ideas that we want to test. So we're in listening mode at the moment. But important to say the strategy hasn't changed. So it's still around a greater focus on emergency care and paediatrics at Gloucestershire Royal, and a focus more on planned care and oncology at Cheltenham General. Not a purist model, so we're not saying all emergency care at one site and all planned care and oncology at another. But what we've seen from some of the discussions and some of the work nationally and internationally is where you can co-locate emergency services. So those services and teams that work together to rapidly stabilize, triage and diagnose patients, that can form the basis of a centre of excellence for emergency care. So it's about those teams being on the same site. Often the same teams will help manage those patients, then use the same kit and equipment. And then over at Cheltenham General, where services need to plan in advance. So this is often where patients will have appointments to come online to access diagnostics, or an appointment for surgery, which can be a day case or it can be an overnight stay. Where those services need that reliable access, because if they don't have that, it results in patient cancellations. We're trying to co-locate as many of those services on the same site as well. So they do have, and they can rely on those access to diagnostic kit and equipment, beds, theatres, critical care, etc. So that co-location of planned care services and oncology starts to define a centre of excellence for planned care. As I said, it's not a purist strategy, and you can see that in our commitment to Cheltenham Accident and Emergency Department. So no change to the model there, and that will continue to be a consultant-led unit from 8 a.m. to 8 p.m. And a nurse-led specialist unit from 8 p.m. to 8 a.m. And in fact, those are the changes that have been in place now since 2013. And in addition to Cheltenham A&E, there's the other things that this phase 2 is not about. So not about the changes that we talked around in phase 1. So those 7 areas that are already in implementation, and again, not a financially driven program. So you'll hear from Tom, and you've heard from others through this series, the changes that the ideas that we're talking about around improving access, improving quality of service for patients, so access, experience, and outcomes. So yeah, you're right, Janet. So phase 2, so 6 more areas, but as I said, in listening mode to see what people think about some of these ideas.
Well, thank you for explaining that to us, Simon. And now we're going to go to Dr. Tom Millard. He's the man who knows everything about diabetes and endocrinology, I think. And the first thing I'm going to ask you is, can you tell us a bit about the service and what it entails in terms of, and specifically about the people in Gloucestershire and COVID? There's been quite a lot of focus on diabetes in recent years, hasn't there?
There has, yeah. Hello, everybody. Good afternoon. Diabetes medicine is the care of people with diabetes, which is an illness of high sugar levels, either because they're not making enough insulin, which is the hormone in the body that deals with it, or they are resistant to the insulin, so it doesn't work. We know that diabetes is becoming more common. Current estimates are that about 40,000 people, adults plus children in Gloucestershire, have diabetes. And we shouldn't forget that the majority of those are looked after in primary care by GPs. However, in hospitals, our specialist teams look after patients with diabetes in outpatient clinics. That's the majority. When they become sick, they look after them in the hospital. That's inpatient work. That might be on their own ward. It might be seeing patients in hospital being looked after by other teams, like the blood vessel teams, which is called vascular surgery, or the kidney teams, which is renal medicine. I think it's estimated that about 20% of patients now in hospital have diabetes. And going back to what you were saying, Janet, in COVID, for some reason, COVID makes people more prone to diabetes. I should explain that I'm actually a dermatologist, but I help manage diabetes. So, I'm not a diabetes specialist, but I do manage diabetes as a team. Another big thing that the diabetes team do is look after complex foot problems. Patients with diabetes have particular and very high risk problems with their feet. They also manage the complex insulin pumps that help replace the insulin in the body for patients with type 1 diabetes. And the team also provides specialist clinics helping manage their kidney disease and helping them through dialysis, which is the process of replacing the kidneys. And then finally, the other really big thing that the diabetes team does is look after women in pregnancy, actually often starting pre-conception with women who have diabetes, who are planning a pregnancy, and then need very careful care throughout, because that has big benefits for the health of their new baby. In terms of endocrine means hormones, which are these chemicals which are produced by glands in the body, like the thyroid gland or the adrenal gland or the pituitary, that go into the blood and have complex actions throughout the body. And when patients are sick because of those, they need specialist care, and that's the other big area of care that this team does.
Thank you. Can you? That's a really good explanation of what it involves. You say most of the care's in the community. There are occasions when people have to come in. Can you tell me a bit about that? Why would people come in, and how you would look after them in the hospital at the moment, and how it was pre-COVID, and how it changed over COVID?
Yeah, so patients living with diabetes, we no longer call them diabetics, but we call them patients who live with diabetes, commonly come into hospital for all sorts of reasons. It might be related to their diabetes. So they might have emergencies where their sugar levels are going up very high. For example, DKA, diabetic ketoacidosis, which is a very sudden, severe illness. It could be that their sugar levels are going the other way for some reason, and it's called hypoglycemia, where their sugar levels drop, making them unwell. It may be that they are admitted because they have, for example, an infection. And when patients with diabetes develop infections, they can become very unwell very quickly. Or they may be admitted because they have other problems that just complicate their diabetes, like vascular problems. But in COVID, it was interesting because the diabetes team, although there's only 5 consultants, they're amazingly highly skilled. They don't just look after diabetes and endocrinology, they also do general medicine, which made them very precious to the hospital. And they did an amazing job of running an entire unit in COVID. We called them pods, where these consultants were at the apex of several pods running the care of wards for patients with COVID, looking after the doctors and nurses under their teams. So the team itself did an amazing job in those pods, in those various lockdown processes. But we also, it had an impact in terms of outpatient clinics. But the other fascinating thing is that COVID has had this effect on diabetes, in that some patients with COVID develop diabetes. Some patients with COVID and diabetes, their diabetes gets worse. So the already precious diabetes team has become more precious and probably more important to the running of the hospital since COVID.
Okay, that's a good explanation of what happened there. Can you tell us how it's set up, the inpatient team now, and your vision of how it might change in the future?
Yeah, so pre-COVID, we had 26 beds, hospital inpatient beds in total, 14 at Gloucester, 12 at Cheltenham. And then during COVID, everything changed for the reasons I've just mentioned. But moving forward, we realised that we need somewhere between 14 and 18 dedicated diabetes and endocrine hospital beds. And at the moment, we've got 14 diabetes and endocrine beds on 9B, which is a ward in the Tower Block at Gloucester. And at Cheltenham, the consultants are supporting the other hospital patients who happen to be inpatients with diabetes. And that's working well for this small team of 5 consultants who are supported by a relatively small number of diabetes specialist nurses as well. The problems are that they have to make daily visits to patients with diabetes and endocrine problems on 2 hospital sites, and it's already a small team of only 5 consultants. They need to make specialist visits to patients with diabetes on wards like the kidney ward and the vascular wards, which I've already mentioned, tend to have a lot of patients with diabetes. And they also have to provide quick responses to referrals from other departments where they need quick input on sick patients with diabetes, and that might include the emergency department as well. So the idea that we're suggesting is to maintain a more centralised inpatient bed base at Gloucester Royal on 9B in order to support acute diabetes management, but also to allow the diabetes team to support general medical patients who make up the rest of the Ward 9B as well. And that would also enable patients who are coming in with pure diabetes problems or hormone problems to be admitted to Gloucester Royal in a much more smooth and quick fashion under consultant care. So
what you're saying is that there'll still be consultant care at Cheltenham, even though the main diabetes ward will be at Gloucester. For those general, if we're going to have a lot more inpatients at Cheltenham, there will still be consultants there to deal with those inpatients? Yeah,
that's a key point. It's estimated that about 20% of patients in hospital have diabetes. Not all of those patients will need review by the diabetes team, but we're well aware that there will still be inpatients with diabetes that do need specialist diabetes input at Cheltenham. And of course, all the clinics at Cheltenham will be running as normal for patients with diabetes, the antenatal clinics as well. And therefore, there will be consultants on site from the diabetes team who are able to see existing inpatients with their diabetes-related problems.
And we've got a bit of a question here from Abby Coleman, who says, will you distinguish in this model between diabetes, the 2 kinds of diabetes?
Oh, okay. Yeah, I think that's a good question. bearing in mind I'm a dermatologist, you have to bear in mind you're not getting an answer from a diabetologist. But what I can tell you is that there are no longer two simple types of diabetes. It's not as simple as the old model of type 1 diabetes and type 2 diabetes. Nowadays, there are patients with type 2 diabetes who develop it at a young age, which I think is called MODY, Maturity Onset Diabetes of the Young. There are older patients with type 2 diabetes who, in fact, are thought to have type 1 diabetes. There's antenatal diabetes, which can include diabetes that just develops during pregnancy, called gestational diabetes. So as a dermatologist, when I meet the team and listen to all of this and learn, it's clear to me that it's no longer as simple as the old type 1 and type 2 diabetes. But my understanding is that the model we're proposing, which is inpatient diabetes at Gloucester on 9B, would include all of the above.
Everybody. Thank you for clearing that up. And can you tell us some of the benefits of what you're proposing? I'm presuming there must be a really good reason why you're proposing it.
Yeah, I think several benefits, Janet. The first is to acknowledge that we have a small team of diabetologists, which is the doctors who are trained to look after, who are the consultants who look after diabetes. And therefore, having them looking after a ward on one site would minimise disruption to services when staff are unwell. We've had several absences related to COVID, for example, maternity leave. And when a team is small to start with, that has a disproportionately high impact. It will ensure safe staffing levels. We also know that when patients are seeing consultant specialists more regularly, it tends to lead to shorter hospital stays, which is good for patients medically. It's good for hospital pathways. Having more specialists in one place is also good. I know as a consultant dermatologist that when we have sick skin patients on the wards, often they are quite complex patients, and it's very good to have colleagues around that you can call on for support. It also means that consultants would be more able to prioritise inpatient referrals from the emergency department downstairs or from other hospital wards. And I think this better organised system would lead to fewer cancelled outpatient clinics. Whereas when we have had consultants off sick and we've been trying to cover two sites, inevitably it's led to other activity being cancelled in order to cover. And we don't like cancelling outpatient clinics if we can help it. So I think those are the main benefits, Janet.
Am I right in saying that ties in with the getting it right first time model that the NHS is aiming for?
Yeah, it does. GIRFT, getting it right first time, has several recommendations which we're trying to follow. But these points that I've made tie in very much with the GIRFT reviews that we've had done, Janet.
And will there be any disadvantages that you can see from the
the only one that really stands out is that because it involves a shift of acute inpatient diabetes patients, so the sick diabetes patients being looked after on a ward in Gloucester as opposed to two wards, one in Gloucester, one in Cheltenham, is that patients from the Cotswolds, from Cheltenham, and their relatives who are visiting will simply need to travel a bit further to see them in Gloucester. And that's the one potential drawback. And we do appreciate at the moment it's not simple travelling between Cheltenham and Gloucester with all the the roadworks and the traffic lights. So that's really the one potential drawback.
But it seems to have a lot more advantages than drawbacks.
Exactly. Yeah, that's what we think.
Yeah. Okay, then. Well, thanks for outlining that vision for us. And I'm sure there'll be, if people have anything to say, they can ask questions and we can ask them at the end, if that's okay, if you don't mind, Dr. Millard. Can we come back to Simon, please? Can you tell us a bit about how people can get involved in this?
Yeah,
and what
sure.
happens next? Yeah.
Yep. So we're offering a mix of ways for people to get involved. So kind of the broader ideas can people can share their ideas through a range of options. So we've got the bus. People are hopefully familiar with the bus that tours around the county. It's in Lydney tomorrow and is in Gloucester in Southgate Street on Saturday. So that's people that prefer to have a face-to-face conversation. As you said, this is the penultimate one of these Facebook Live sessions, but they're all available as recordings. We've got cardiology on Friday. And then in the beginning of July, we have a number of engagement workshops. And if people wanted to register to attend one of those, the ticker at the bottom, you can see the website address there to register. And they're running between the 5th of July and the 12th of July. Also on that website address is an online survey. So the survey closes on the 29th of June. So encouraging as many people as possible to complete that, to share views. And perhaps just a number I'll drop in. So a telephone number for those people that want the information in larger print or in Braille, or to access it in other languages. The telephone number is 0800 0151 548. So yeah, a range of ways that people hopefully get engaged so we can hear as many people as possible. And then in terms of next steps, so as I said, this is the engagement phase. So we're in listening mode. We take all the feedback we've received, so chat on these Facebook events, the face-to-face feedback we've had, and then the survey. And we produce something called an output of engagement report, which pulls out the key themes. So here's everything we've heard, and here's things we need to consider alongside the ideas that we're sharing. And if there's anything we need to tweak to address any concerns or issues, then we'll do that.
And do you have a time scale for this? I know the 24th is when the engagement ends, the public engagement exercise. But after that, do you have any kind of time scale when people might get some answers about?
Yeah. So yeah, the end of June is the survey closes, and in July we'll run those engagement sessions. So it'll be the end of July, early August, where we'll have that output of engagement report, which again we'll share those publicly. And then depending on the scale of that feedback, we'll determine what we do next. So if all the feedback is positive, then we can think about implementation planning. If there's some things we need to consider or we want to go back and have more discussions, then we can move into public consultation. But it will depend what we get through the engagement phase.
But if people have anything to say, now is the time to say it. They need to say now.
Yes,
this
please.
Is part of the engagement exercise. It's not a proper consultation. It's an engagement exercise you want to hear, and you want to listen to what people have to say as you draw up these vision for the future of the NHS in Gloucestershire.
Correct. Yeah. Yes, right.
Okay, then. Well, thank you for coming today, and thank you for explaining that, and thank you, Dr. Millard, for letting us know what's planned for, or what's suggested for diabetes, because it is actually a really important area at the moment, isn't it? And we shall see you on Friday, where we'll be talking about cardiology. And if, like I say, if you've got any questions, please file them. I'll ask them to the people. These are the people, you've got them in front of you now, the people who in the know. We've got Simon Lansley, who's the Director of Strategy. He'll be the one who'll be taking any of these things forward. And Dr. Millard, who wants to know what you think about their visions for the future. Hang on. I have got one question coming up, which I didn't see here. It's got patients in rural areas, and this is by Stephen Andrews. Patients in rural areas may find that getting into Gloucester may be a challenge. Will there be outpatient support provided through the community hospitals? Will those services essential to prevention of problems, podiatry, etc., be available at community hospitals? I think they are, by what I've read, but I'll just leave that over to you, Doctor, to answer
I can
that.
certainly say that diabetes services are already provided at community hospitals, which is very important to Gloucestershire. For example, Tewkesbury Hospital, and that there's no plan to alter that model. The diabetes team also has a brand new consultant who is a community diabetes consultant dedicated to working in the community.
So the people have got nothing to worry about if their conditions are being managed in the community at the moment. It'll carry on. It's just for the
Yeah.
sickest patients, the inpatients.
Yeah.
Am I right?
So what we're talking about with this particular bit of Fit for the Future is just the diabetes and endocrine inpatients. It doesn't involve any change to the provision of outpatient services in the community hospitals, Cheltenham, Gloucester, the virtual clinics, and the community diabetologist who was appointed, I think, about 4 months ago and is now already doing community diabetes clinics.
Okay, thank you. Well, I hope that answered your question. Any more questions, keep them coming in and we'll put them to the experts. And thanks for joining us today. Like I say, maybe see you Friday for cardiology, and goodbye for today. Thank you.